Hi, this is Carol from the STS. Thanks for joining tonight. I'm the Senior Clinical Manager for the databases, and tonight we have a presentation on the new stat scores, new patients, and the congenital upgrade. We'll get started here on the call. Our moderators tonight are Dr. Jennifer Nelson and Dr. Ram Subramanian. And I'm going to hand it over now to Dr. Subramanian. Thank you.
Well, hello. Thank you. Welcome to everyone to this webinar. I really thank STS for giving us the opportunity to talk to you and update you on some of the new and exciting things coming to the task force. As you all know, I'm Ram Subramanian. I'm the chair of the Congenital Heart Surgery Database Task Force. And I will be talking to you initially about the new stat scores. And then I'll hand it over to Jennifer Nelson. And Dr. Nelson has worked tirelessly with Dr. Scholl in helping the data collection form be upgraded to include fields for patients who are over 18 years of age and undergoing congenital heart procedures and being entered into our database. She's going to discuss those fields in detail. I want to thank Dr. Nelson in advance, not just for being here this evening, but also for the incredible amount of work, the long phone calls and tireless efforts that she has put in making the data collection form better, especially for the subset of patients over 18 years of age with congenital heart disease. My task for the next 10 minutes is to walk you quickly through the stat score upgrade project that we successfully completed and what we will be rolling out for the upcoming harvest close and analyses. Obviously, this audience is very clear in knowing what a stat mortality score is. The mortality score was initially developed in 2009 in combination with the Society of Thoracic Surgeons along with the European Association for Cardiothoracic Surgery. Together, it was called the STAT mortality score. The idea of the STAT mortality score is to stratify congenital heart surgery procedures into 5 categories of increasing mortality risk. So it's important to understand that these scores are empirically derived, that is, they are based on prevailing numbers, contemporary surgery that's being done, but even more importantly, it's a mortality metric. So it's a metric that's fundamentally different from, say, the Aristotle score, for example, which is based on complexity of the operation. The STAT score is based entirely on the mortality that is associated with a given congenital heart procedure in the database. And this is going to become important as we go through in future to see where the scores are now. The stat mortality scores help us characterize the case mix of congenital heart surgery providers. As we're all aware, there is substantial difference in the case mix from one institution to another, and therefore, the stat mortality score provides us some kind of a balance to understand the case mix within the various institutions. It's also used to stratify center-level outcomes. So remember, this is just risk stratification. It's not risk modeling. It just allows us to say, this is the expected mortality for stat category 1. This is the expected mortality for 2, 3, 4, so on and so forth. It is important to know that stat categories are also used as auxiliary variables in the congenital heart surgery STS mortality risk model. Now, I'm sure there are statistics experts in the audience today. I'm not one, but I can tell you my understanding is that the stat scores are simply used for Bayesian shrinkage estimation. That is, if the number of procedures is very small in the database, and if we have to borrow mortality data for those small procedures, instead of getting it from the entire universe of congenital heart surgery operations, the stat categories allows us to estimate shrinkage variables from within the stat category in which that procedure falls. So again, stat categories are only a small auxiliary part of the mortality risk model, and you'll see why this conversation is important as we move on. The stat metrics are widely used in outcomes research as well as in quality improvement initiatives. In fact, most surgical publications now utilize stat metrics in some form of another. For all these reasons, having contemporary stat mortality scores is crucial, particularly because since the mortality scores were established in 2009, number one, practice patterns have changed. There is an era effect. We've introduced new procedures for which we did not have stat mortality scores because those procedure codes didn't exist in 2009, or we assigned mortality scores based on expert opinion because we didn't have enough procedures to get empiric data in 2009. So we felt a decade later, it is important to bring the stat mortality scores contemporary. Next slide, please. To that effort, a large STS ANP project was undertaken, and the data are presented in this paper that's shown on this slide. The lead author is Marshall Jacobs. Marshall and the group, and I was privileged to be part of this group, presented their work on updating the empirically based tool for analyzing congenital heart surgery mortality. In the letter that went out to all the database participants, there is a link to this paper. For those of you that don't have it immediately available, here is the DOI, here is the PubMed index for this paper. The next 4 or 5 slides that I'm going to go through are all data that emanated from this analysis, and this analysis is published in the World Journal of Pediatric and Congenital Heart Surgery. Next slide, please. So as part of the stat score upgrade, we looked at the entire universe of operations that were performed between January 1st, 2010 to June 30th, 2017 at 110 centers. So the study cohort included 160,000 operations, which included 235 distinct procedure codes, which is substantially larger number than there was in the 2009 stat scores. An important point to note is that these 235 procedure codes include 35 new unique procedure combinations. So there are new combination procedures where we found that the mortality of the highest stat score procedure does not capture the mortality of the combination procedure. Therefore, we gave these 35 unique procedure combination codes and put them into the analysis for the 2020 stat scores. The endpoint for these are still, like I said before, mortality as defined in the Congenital Heart Surgery Database. The study cohort was then taken to a validation cohort of about 47,000 patients who underwent surgery between July 2017 and June 2019. And as you can see in the graphs, we found that mortality went from 0 to 36%, as you can see in the right side graph. And statistically, we estimated what best number of stat mortality categories appropriately provides us an area under the curve. And it was felt that number of categories remaining at 5 stat categories, as you can see in the arrow that's pointing in the left side figure, 5 stat categories had an AUC as high as 0.7, high 0.7s, close to 0.8, and accurately captured the difference in mortality between the various procedures. Next slide, please. So then we took this universe of 235 procedures, and as you can see in the figure, put them into 5 different stat categories. The stat categories were chosen to maximize intra-category homogeneity and inter-category heterogeneity. So as you can see in table 2 shown below, the range of mortalities varied from 0 to 1.3% for category 1 versus all the way to 12 to 38% for category 5. We then converted this range of mortality to range of scores, and the range of scores went from 0.1 to 5.0. And in the last row, you can see the number of procedure codes that are within each stat mortality category. Based on all of these, we assigned the 235 procedures specific stat mortality scores and specific stat mortality categories. And what you're seeing in the table that's on the top is that several procedures changed stat mortality category. So for example, if you look at the first row, the procedures that were originally stat 1, there were about 25 of them. One procedure now became stat 2 category. Same way, if you keep going down the line, you can see some stat 2 procedures change categories, some stat 3 procedures change categories. But regardless, we now have a new set of stat scores and contemporary stat mortality categories for 235 operations that are being performed as part of the Congenital Heart Surgery Database. Next slide, please. We know this is a lot of information. So what Leanne has done is she's kindly come up with this appendix, what we call Appendix C. I'm just giving you a snapshot of Appendix C. It's a long list. This is going to be universally available to all of your data managers. The list basically goes like this. It gives you the procedure harvest code the procedure name, the stat mortality score, and the stat mortality score, which is what was in 2009, the new stat mortality score in 2020, the stat mortality category that was in 2009, and the new stat mortality category in 2020. We have this list for all 235 procedures. It's all going to be available for your data managers for immediate use. Next slide, please. So what does all this mean? What this means is that starting in the spring 2022 harvest analysis, that is this March, when we finish this April, when we finish the harvest close and start the harvest analysis, we're going to start utilizing the 2020 stat scores starting now. This should give us a lot of satisfaction because these new 2020 stat scores are empiric. Every one of the 235 procedures is actually in our database, and we have verifiable mortality numbers. It is statistically valid. It is completely reliable, peer-reviewed, published. Most importantly, it's derived from contemporary surgical procedures. This is no longer data that are 10 years old. These are data as of now, so they are far more relevant to the procedures that we're analyzing right now. The STS risk model stays exactly the same. The risk model does not change. So I'm going to remind our conversation from before that the only change will be because stat scores are an auxiliary variable. That's the only change that will happen to the risk model. The original model stays exactly the same, so you shouldn't have to worry about it. The things that will change are the stat scores may differ for certain procedures. I told you, a few of them change stat categories. What this would mean is that if the procedure had a different stat category until now, in the new harvest analysis, it may have a different stat category. That, for the sake of the data managers, may also have an impact if it is part of a multi-component procedure. If there were 4 or 5 component procedures and you had picked the highest stat score procedure based on the older stat scores, you will get a primary procedure mismatch if another procedure now has a higher stat score. That doesn't mean you coded anything wrong. It's just because the stat scores changed. And I was just talking to Chastity, our data manager consultant before. This is going to happen in a very, very, very small minority of procedures where they're going to be multi-component, and one of the components is now the new highest stat category. Lastly, the cohort of procedures that constitutes the individual stat category is going to be different between your fall 2021 harvest analysis and your spring 2022 harvest analysis. So you can't have a direct comparison saying, oh, my stat 4 mortality was this last year, it is this year, because the cohort of procedures that makes up the stat category is going to be different. But all said and done, we are very, very excited that now we have stat scores that are contemporary, that are statistically valid, empiric, and we're really looking forward to roll this over to the spring 2022 harvest analysis. I think that's my last slide. I'm going to stop there, and I will turn things over to Dr. Nelson. Again, Dr. Nelson, thank you so much for doing this. You are an incredible partner in the process. Thank you for your time.
Thank you, Ram. Excellent presentation, and thank you for your kind comments just then and earlier. So good evening, everybody. Happy St. Patrick's Day. Thanks for joining. It's going to be my goal this evening to introduce the new adult congenital module within the CHSD and to leave you with an understanding really of the motivation behind this initiative and the important benefits that we anticipate from its use. So for this presentation, the definition of an adult congenital patient is a person 18 years of age or older with a history of operated or unoperated congenital heart disease. As this audience knows well, but it's probably worth noting, these patients do have cardiac surgery for both congenital and adult acquired indication types. Next slide. So the need to optimize data collection for adult congenital patients has become more pressing as we have observed increasing adult case numbers within the CHSD since 2000. At this time, adult cases represent 10% of CHSD records. Next slide, please. In recent years, the STS has recognized that the current STS databases lack the necessary granularity for capture of several variables relevant to this growing ACHD population. For example, as you can see here, several traditional cardiovascular risk factors such as coronary artery disease and hypertension were not previously captured by the CHSD, but these factors may modulate cardiac surgical outcomes for these patients. While the comorbidities that are captured by the STS-CHSD are appropriate for the pediatric congenital population, next slide. Thank you for advancing the slides. Some variables such as necrotizing enterocolitis or gestational age may be less relevant for adults. In contrast, the STS-ACSD provides excellent capture of conditions relevant to acquired heart disease, but it does not capture genetic syndromes and other extracardiac defects. Thus, for the adult congenital population that straddles both of these databases, there has been incomplete capture of important information. Thank you. So to summarize those last few slides, the growing and aging ACHD population has a unique set of patient characteristics that have previously not been well captured in any single data collection form. Some centers have elected to enter these patients into both the CHSD and the ACSD, which is time consuming and it involves duplicate data entry for the fields that exist in both. For all these reasons, optimization and organization of data collection for ACHD is needed. The good news is that we're hosting this webinar to introduce an initial solution to this problem. But first, I would like to emphasize why all STS cardiac surgeons should care about this topic. For adults, the risk associated with being a congenital patient undergoing cardiac surgery is unknown. Existing risk models do not include many of the variables relevant to the ACHD population. Thus, it is likely that operative risk may be under or overestimated by currently available risk models. Also, quality reports for particular operation types may suggest that an institution is performing worse than expected if risk adjustment is not optimized for ACHD. To optimize data collection for these patients, a working group recently identified a list of recommended variables for inclusion in this upgrade of the Congenital Heart Surgery Database. This table shows a summary of the information that is collected by these new variables. The majority of the new fields were in the operative sections, and they provide additional detail related to valve, aortic, and VAD procedures. Only pertinent procedural data fields will be seen by the data managers, and they're entering the data. So for example, the data manager will only see aortic surgery fields for those patients who are undergoing aortic operations. I'm happy to report that the adult congenital module will now serve as the repository of information for all adults that are being entered into the CHSD. And this module is aiming to combine relevant CHSD with relevant ACSD fields while minimizing double capture of information on the data collection form. So hopefully this will be a more efficient strategy to accurately represent this population. Next slide. We'll give you a quick preview of what the ACHD module looks like. So this text appears pretty small here, but I wanted you to have a chance to be able to see it. Basically, the added detail for procedures such as valve, VAD, and aortic operations is basically cut and pasted from the adult data collection form to maintain the same variable names and the same data structure. In this way, procedures that are common, such as AVRs, aortic valve replacements, may be analyzed together with aortic valve replacements that are being captured in the adult cardiac surgery database, so that programs that are performing a high volume of adult cases for congenital patients will still be able to identify and count those cases. So I think this is one of the more important points here. After implementation of this module and for the foreseeable future, the surgeon is the one who decides which data collection form to use. And when I say which data collection form here, we're talking about patients over 18 having cardiac surgery. I've left general thoracic off the list here. This is cardiac surgery for congenital patients. Your surgeon will decide if the patient's information should be entered into the CHSD, which would mean this module, or the ACSD. And you should only choose one. For this part of the process, the vendor software stays the same. So sites that have access already to the CHSD will get access to this module, the ACHD module, with this upgrade. The uptake of the adult congenital module in the CHSD is expected to mainly involve surgeons and sites that are already going to enter these cases into the CHSD. However, in the future, there are initiatives to include surgeons who do not currently have the CHSD, and 2 of those potential solutions are presented here. So to help us understand how and why programs are currently reporting certain adult case types to one registry or the other, the CHSS and the STS have partnered to distribute a survey for congenital and adult cardiac surgeons. So you should look for that in your inbox now. We're going to use the survey information to better understand current surgeon preferences related to reporting for controversial subgroups, such as bicuspid aortic valve patients, patients with Holcomb and connective tissue disorders. So please do fill out this survey when you see it, because it's critical that all practice models and all surgeons are well represented. So I think this kind of summarizes the benefits that we see for this adult congenital module. Basically efficient, I think we're trying to say this efficient capture of data for ACHD patients is important, and it's now possible by way of this module. We do recognize that this is going to be an iterative process, and we're hopeful that the ongoing surgeon survey will help us reach a more refined definition and establish some new guidelines for certain patient groups in order to better serve or to best serve patients, surgeons, and programs alike. Thank you very much for your attention this evening. I think we're moving into a panel discussion where we can take some questions.
Yes, and Dr. Subramanyan, if you wanted to come back on camera. And we just have 2 comments in the chat box. If anybody has questions, you can raise your hand. We're happy to unmute you. If you have a microphone on your computer, or if you'd like to put it in the chat box and we can read it for you and go from there. And right now, Dr. Nelson's just flying solo. Dr. Subramanyan will be with her in just a second. Nice presentation, Dr. Nelson. Thank you so much for your work on this project. It's really been a labor of love for you, and I'm glad to see it finally come to fruition.
Thank you, and the STS staff for your help as well, and for advancing the slides. Thank you.
Yes, I'm having internet issues, but yes. Okay. And thank you, Dr. Subramanyan, for your presentation and an open discussion now. Yep. Dr. Nelson, did you want to update us on any of the work that you're looking at regarding the risk models for adults that are coming, that you're working on? I see that Becky Sam will have a question or statement for you soon, but any information you'd like to share on that for the group? Or
sure.
I know that's very exciting.
Yes, it is. I think the bottom line coming out of that project is that we're making significant progress and have definitely established that there is room for improvement in as far as on top of the work that's already been done to develop the existing cardiac surgery risk models for adults. The initiative to capture the adult congenital population is not specifically procedure focused. So our aim is to include patient-specific factors, including congenital diagnoses and congenital procedure types. So we are seeing a great benefit with undertaking that job, and are getting close to a model that we're very happy with, and are almost ready to move into our validation cohort. So more to come on that, and we hope to operationalize that in the next year. And again, the goal is to be able to have an online risk calculator to help predict operative mortality risk for adult congenital patients undergoing any type of cardiac surgery. So more to come.
Yeah, thank you. Thank you.
That's so exciting, Dr. Nelson.
Totally,
So
Jen. This is
exciting.
great. Carol, just one other point I'd like to add. I want to give a shout out to the STS staff and Chastity for all the work they have done with going through these DCF with the new modules with our data managers. And again, as Dr. Nelson clearly explained, and I said it in one of the last webinars as well with the data managers, so I just want to make it clear that all these additional fields will only open up in the Congenital Heart Surgery Database module if the patient's age is calculated to be greater than 18 years based on the date of birth. Otherwise, it's not like you're going to have to fill this out for every patient that you're entering into the CHSD module. We've been very careful to make sure that this will only show for the patients whose ages are over 18 years. That's number one. Number two, there are a lot of parent-child relationships. So if it's an aortic operation, only the aorta fields will show up. If it's a conduit exchange, you're not going to be filling aortic fields. It's very specific to the procedure that the patients are undergoing. One last word about this. We're still in the process of programming the data collection form. I'm working with the database task force as well as IQVIA and our vendors to find the appropriate time when we'll be able to roll out the DCF. We don't exactly know when the DCF is going to be updated and upgraded. Whenever the next upgrade of DCF happens, that's when you'll start seeing these additional fields for patients over 18 years of age. So again, thank you, Chastity, for the yeoman task, and thank you to the STS staff.
Thank you. And I just wanted to clarify on that, the programming for it's been complete, and we're just waiting for the implementation from IQVIA, STS, and all of those. So the hard work's been done on our side, and task force has done a great job leading that. There is a comment in the chat box from Becky Sam, who's one of our core group data manager members. And she just, I think her question is looking for some clarity on the guidance you provided, Dr. Nelson, regarding surgeons deciding whether or not or where, and her language is whether or not to use the ACSD module. But I think what's needed here is maybe a little clarification regarding your statement about not whether or not, but where that data is collected.
Right. So for programs who are entering patients into the CHSD, the age is going to be the trigger for this module. So there would not be any decision-making needed. If you're entering patients into the CHSD, again, the age of 18 or older is going to populate these fields for data managers. For programs who have been entering congenital patients into the adult cardiac surgery database, at this time, that decision remains with the surgeon. So if that was the intended database, plan, that's fine. But we do not see, and we do not foresee in the future, a need to continue entering patients into two different databases. It is the hope that with the surgeon survey that's currently ongoing, we would refine our, meaning the STS surgeon, membership definition for what is an adult congenital patient, such that we could establish a little bit better guidance on where we hope to capture all of this patient type. The point obviously is to improve our understanding of outcomes and to be able to continue to develop future iterations of the risk model to provide best possible information to patients and family. I don't know if that makes things more confusing or if that is helpful.
It's super helpful. And I think what was additionally clarifying for me is that you had said that you're working on developing a list of procedures that you will provide for the data managers as guidance as to where these specific cases get entered. And I think that will be very helpful for us in helping to educate sites and kind of guiding them to which database and providing education for them. So thank you. I think that was helpful.
Right. I mean, a specific list, an exhaustive list, is probably not ever going to be possible. We know this is a heterogeneous population, lots of different procedures and procedure combinations, but we can begin to move in the right direction. And what we want to do is work with current surgical surgeon preferences, not go against the grain here. So the survey is super important, and I hope people will respond so that we can understand how to best serve you with this new initiative.
That's wonderful. Thank you. Dr. Subramanyan, did you want to add any words of wisdom regarding the upgrade and what your hopes are in the future for the database?
Yeah, I'm super excited, especially about these additional fields for the older congenital patients. I'm really excited. One day we may have a specific risk model, like Dr. Nelson said. So this is important. We assure you we'll work to, in the future, maybe try and integrate both the adult cardiac and the congenital in an aspirational way for this subset of patients. I don't know if that can be done, but we're going to try and make data manager life as comfortable as possible to minimize duplicate data entry. I'm really excited. I think this is an important effort. I want to thank Dr. Nelson. Also want to thank Dr. Scholl, who's not on the call today. Frank Scholl was also instrumental in developing these fields along with Jen Nelson. So thank you to both of them. I'm really looking forward to rolling out the DCF when we can get everything else done for it to be rolled out.
Actually, I had a large working group.
Thank you.
There's plenty of people suffering along with us.
Okay.
Team support.
I'm not seeing any more comments come in or questions. If anybody has a comment you'd like to put in the chat, please do, or raise your hand and we can unmute you. And I guess we don't want to take up extra time if we've covered everybody's questions. Like Dr. Subramanyan had said, we are reviewing the date for go live of this new version, and more information will be coming from the task force in the coming weeks. So please look out for that, and we'll be sure to notify data managers on our upgrade calls. Any other, I guess we're able to close. I don't see any other questions or chat, and I'll leave it to you, Dr. Nelson and Dr. Subramanyan, how you'd like to finish this up.
We do have a question that came into the Q&A. Dr. Subramanyan, I don't know if you wanted to tackle that one.
The one from Dr. Kremlau? Yeah,
Sure. From Dr. Karamalu.
Tara, excellent point. Tara writes, it's important to have a debrief after a few months or years to assess questions or comments. It's absolutely true. This is where our amazing data managers, they really do a terrific job of communicating what does and does not work for them. And we have a terrific core group of data managers. We have Chastity who will look into this. Tara, your point is very well taken. This needs to keep coming back and forth from the CHSD constituents, from the surgeon leaders, from the surgeon participants, from the data managers, and we will iteratively continue to make this better. Again, another shout out to our amazing data managers. We don't have a database if we don't have the quality and the diligence that comes from every single one of our data managers. So again, huge shout out to them. They are instrumental to keeping the database going. With that, I'll turn it back to you, Carol and Leanne.
Yep, we have a question in the Q&A. It's just to be certain, we should be looking out to correct the issue in the primary procedure caused by the score category updates.
Yes, you will. So when you submit your new set of data at the time of the harvest submission, you will get a primary procedure mismatch report. And the primary procedure mismatch report is intended to capture any mismatches that come because of the score category update. And we would request that the data managers please look out for these mismatches and go back and correct them so your data will be appropriately analyzed as it is intended to be. Thank you for the question.
Okay. Well, very nice presentations, Dr. Subramanyan and Dr. Nelson. Thank you so much. If you're comfortable with ending the call a little bit early and no further questions are waiting, I think we're good there. I'm sure that everybody appreciates, just like we do, your time and leadership for these very important initiatives for the database and for the patients we're serving. So thank you very much. I hope you all have a great night.
We did have
one more question.
Yeah, we have one more come in. So I'm sorry, before we hop off real quick. We have created dashboards.
Just when we were home.
Just when we were good. That's okay. That's all right. We are happy to take it. So just when we have created dashboards to match STS rules and definitions. What is the rationale for not updating local data?
You're welcome to update local data. Am I understanding the question right? You're welcome to update local data if there is a catch for that.
I think that's what we encourage from the STS is to update your local data. Okay.
Got it.
All right. Now it's time to say goodnight. So thank you everybody so much for your time. Thank you, Dr. Subramanyan and Dr. Nelson. And thank you for your leadership and guidance. And thank you for caring for our patients so well. I hope you all have a great night and take care, everybody.
Thank you,
stay safe. Thank you so much for joining, and happy St. Patrick's Day. Bye.
Thank you all.